HAT is a parasitic disease, so it's not a virus, it's not a bacterium, it's a single-cell organism. They are way larger than bacteria, and also way closer related to humans in a certain way, in a biochemical way. So it's a parasitic disease occurring only in Africa, sub-Saharan Africa, and it's one of these diseases I mentioned before, which are exclusively existing in rural areas. Sleeping sickness has a very, very interesting history, and to answer this question, I probably should go a little bit into this history and take a broader approach, because at the moment, only about 2,100 people seem to be affected per year. That's what has been reported last year to the WHO. But this disease has been very, very widespread. We have had epidemics in the early 1900s in Uganda, in Central Africa, where up to 5 million people were actually dying per year. We had then disease control, very, very big measures, expensive measures by the colonial forces, the British forces and the French forces, that actually pushed back the disease to around 5,000 cases per year in the 60s. And with the decay of the colonial forces and problems occurring, decay of public health systems, the disease came back. In 1990, we talked about 20,000 people per year, and mid-1990s towards 2000, there were reports of over 100,000 cases per year, and the estimate due to underreporting was that there were more than 300,000 patients actually affected per year. And then a set of measures set in which actually limited the disease and brought it down to currently about 2,000 patients. This disease is set for elimination in the year 2020. There are a number of countries where the disease occurs, mainly Central Africa, and above 80% of the disease actually occurs in Democratic Republic of the Congo. What we actually don't exactly know is what is happening in Central African Republic and also in South Sudan, because these are, again, crisis areas, and sleeping sickness follows crisis because it needs an active detection and it needs active prevention measures, treatment, above all, diagnostics and treatment. And this isn't happening in these areas. So the 2,000 cases we currently see may again be a gross underestimate. There is a second form of sleeping sickness occurring in East Africa, which is almost eliminated. There are currently about 50 patients per year which are reported, but also this disease has a very, very big potential for really fulminant returns. This has happened in the past, so also there we have to be very, very cautious. This disease is caused by a slightly different parasite and is distinct from the other forms through a very rapid development. Both diseases are usually fatal. There is a new body of literature that says some people are actually surviving. The dogma for many, many years was everybody dies. And the difference between these two forms is in East Africa, you're dead within half a year, and in Central and Western Africa, people die typically between 3-5 years after infection. Spread by tsetse flies. It's a very interesting insect. I'm not an entomologist, so I'm not an insect specialist, but tsetse flies are very, very special, which has a big impact on the epidemiology because they are so-called larvipar. So at once, they don't lay like mosquitoes thousands of eggs, but they actually lay one larvae at one time in a very, very selected special area. Usually this is sand, which is semi-wet. So that's at a river border, for instance, and that's where people wash. And the tsetse fly with her first meal, if they feed from a person infected, they pick up the parasite. Parasite goes in the insect through a very, very complex change and life cycle. And then when the insect feeds again, this tsetse fly feeds again, it may infect the next person. And it is of real epidemiological interest how these larvae are born and where they are actually born, because that's very often a place where a lot of people are gathering for washing, for body hygiene, etc. This is a very rural population. That's really what we have been talking about for neglected diseases, a typical neglected population, usually living in a very remote places that are hardly accessible, where health system is very weak or not existing, where the next health center may be very far away, where improvements like roads, like concrete houses have not yet really reached. There are two stages of the disease. The first stage, where the parasite circulates in the blood and in the lymph after the person has been bitten, are relatively unspecific, which is a problem because it may resemble malaria, it may resemble quite a few other diseases. So that is headache, fever, a malaise, just like people have joint pains, etc. There may be a rash, and there may also be a chancre. A chancre is an inflammation at the place where the insect has bitten, but this is relatively untypical. And after certain time, around half a year to a year, for the Western and Central African form, the parasite actually is able to penetrate in the brain, and we call that passing the blood-brain barrier. And then a whole set of psychiatric changes may set in. There is a lot of things changing in the body. There's immune problems, and in the brain there is changes in the immune system. You have changes in the myelin. That's the sheet that is actually covering our nerve cells in the brain. And with this you have changes of the personality. That's the very subtle changes in the beginning that you can sense. People start to sing, people start to talk a lot. And then this goes into any form of schizophrenia, of paranoia, of aggression. So it's a very, very bad disease. As the disease progresses, people then also will get weaker. And at a certain stage, the sleeping pattern actually changes. So they will fall into a fragmented sleep. That's where the name comes from. They basically, during the day, they just all of a sudden fall asleep. And at night, also, they have this sleep fragmentation, which formally has been said there is insomnia, so no sleep at night, which is not correct. It's just a fragmentation of the sleeping pattern. And then towards the end, people get cachectic. They don't really eat. They lose appetite. They get secondary infections, and that's what usually leads to death. Diagnosis is complicated because we have to distinguish still between the two stages. As I said, there are different medicines, different drugs that are being used for first and second stage. So there has to be a diagnostic tool to distinguish, and this is done through a lumbar puncture, which has to be done in you have to imagine, very rural health center, very painful. If we do the same in Switzerland, this is a big thing, the medical doctor coming, anesthesiologist coming, and there it's just like basically done under the mango tree. And this has actually prevented widespread treatment and treatment very close to the patients. Currently, it's treated by several means. It depends on the stage of the disease. First stage is treated by pentamidine in Central and Western Africa, and suramin in East Africa. Suramin, actually the oldest drug that is still sold in the world. We will celebrate, in quotes, we will celebrate 100 years of suramin, depending on how we count, probably next year. And pentamidine also has been developed in the 1940s, so two old drugs, but they work relatively well, but both have to be injected. In the late stage, there is a lot of progress we made, and currently the disease is treated by infusions combined with an oral tablet. And we are working on new tools that are actually developed at the moment to even bring this to a fully oral medication in the next year. Originally, second stage disease was treated with melarsoprol, which is arsenic compound, organoarsenic compound that had been developed by a Swiss chemist and medical doctor in 1949, also a very old drug. The main problem with melarsoprol is so-called encephalopathic syndromes, which may occur in 5 to 7% of the patients and actually lead to the death of the patient. It's a very horrible thing because the patient, while treated, gets better, seemingly better, and all of a sudden this sets in with coma and with severe cramps and relatively sudden deterioration. So when I started working on sleeping sickness 25 years ago, we had a case fatality rate, so people dying from treatment or during the treatment of 5 to 7%, and we are now down to 0.1%. In the meantime, there was a lot of work done. First, we tried to develop a first-stage drug that would have been orally applicable. And actually, this drug that had to be stopped during development after many years of work, which is not untypical. This happens, but it was bad luck because there was no good pipeline. And then some very smart people had a good idea to actually combine two existing drugs. One is eflornithine, that had existed before but was very, very expensive, and combining this with another drug, nifortimox, that had been used for the American cousins of sleeping sickness, Chagas disease, which is also caused by trypanosomes. Combining this actually led to a treatment that is lasts 10 days, still very complicated, infusions are necessary, but could bring down the fatality rate to 0.1%, which is a miracle compared to what we had before. It's relatively difficult. It's not like using a mosquito net. There's two ways. The personal protection would be evading the places where tsetse flies occur, but this is very difficult for some people, as I said, because tsetse flies live where people live. And the other is so-called vector control. There are traps that can be placed in strategically interesting places which actually attract the tsetse flies. These traps, you have to imagine, they're about 1 meter high, 1 meter wide, made of blue, dark blue and black fabric. The dark blue actually attracts the fly, and the black place is where they actually sit down. So now you can impregnate these nets or these traps with chemicals, or you can shape them in a cone, because tsetse flies always start away flying upwards, and if you put a net there, they get trapped and can be collected. So that's a very, very helpful measure, relatively expensive. Also, because we're talking about the poorest of the poor, and very often these traps have been used in the past to actually for other purposes, clothes, fishing, God knows what. And a couple of years ago, there was actually a new invention. Somebody found out after use of like 50 years of different types of traps that very smaller targets, much smaller traps are actually much more effective, and they cost less and they are easier to maintain. So this tool actually helps us very much in the control and also in the elimination of sleeping sickness. Yeah, there's many challenges of fighting human African trypanosomiasis. I guess it's one of the most difficult diseases actually to get rid of, even if it's set for elimination in the year 2020. The main problem is it's a rural disease, very, very difficult access to these people. People have a lot of problems to actually access the health systems to get diagnosis. And this is very much aggravated by political problems. We are talking about the Democratic Republic of the Congo, where, for instance, for the past 2 years, people have been waiting for elections. They don't happen, which is causing huge instability. And the instability is the ground for sleeping sickness to come back, because there's no investment in health. There's no investment in health in rural areas. We have the war ongoing still in Central Africa, so nobody really knows what is going on in southern eastern Central Africa. It's too dangerous to actually go there. Very rare visitors. Same is in South Sudan, which where we thought, peace is coming, and South Sudan is back into pure chaos. So the corner between the Democratic Republic of Congo, Central African Republic, and South Sudan may still bear a lot of cases. And then diagnostics, we know today so-called rapid tests. They can be compared to pregnancy tests that you buy in the pharmacy. Drop of blood is good enough. But until today, still the recommendation is to actually establish the parasite, to find the parasites, to confirm the diagnosis before treatment. This may actually change when we will have new drugs, new compounds that are currently researched. Towards the end of this year, the Drugs for Neglected Diseases Initiative, DNDi, hopes to have registration of a new oral drug against sleeping sickness. And this, of course, will be a tool together with the rapid tests that can help to actually better approach people in remote areas. At the moment, the disease is treated with suramine and pentamidine, two very old drugs, invented in 1990 and 1941, respectively. Drugs that today would never be registered because of their adverse drug reactions they cause. Pentamidine still used in certain co-infections in HIV/AIDS, but considered a very difficult drug. For us, it's one of the easy drugs. It's used in first stage of the disease, meaning when the parasite is still circulating in the blood. In second stage disease, when the parasite has passed the blood-brain barrier and can be found in the brain, we are using NECT, nifurtimox eflornithine combination treatment, which is a relatively complex treatment lasting 10 days with infusions that have to be set, plus a drug that is given orally. So people have to go far, have to go to the hospital and have to be hospitalized. Yes, they do. Compared to drugs, we are generally thinking they're safe. You can have seizures if you apply eflornithine. There is a neutropenia, decrease of platelets in the blood, so blood clotting can be affected. But compared to what we used to use with melarsoprol, this old organoarsenic drugs, this is really minor in terms of problems, and compared to the effect of the disease, which is normally fatal, this also is a minor problem. So we are, with the effects and with the risk-benefit assessment, actually relatively happy at the moment. The main complication is more on the practical side, that people actually have to travel far and that they have to stay at the hospital for up to 14 days. There's a lot of research ongoing. Typically, trypanosomes have been used as a model for many molecular biologists. They are probably the best studied parasite at all, because they're on the molecular and biochemical level so interesting. And there's two new drugs that actually are developed. One actually not coming from top-notch research, but from actually looking into already existing drugs that have been stopped. There is a recycling of already researched drugs. The Drugs for Neglected Diseases Initiative actually went into so-called libraries of drugs that have been under development and have been stopped for multiple reasons. And they were actually screening parasites for activity with these compounds, and fexinidazole was one of the compounds that looked very promising, was very active, and now has been studied in clinical trials very extensively over the past years. And there is a so-called dossier at the European Medicines Agency currently under review, and it looks like fexinidazole could become a new drug at the end of this year with market authorization, with registration, and then, of course, marketing authorization in Africa to follow, to be used against sleeping sickness. And the beauty of this drug is that it's an orally applicable drug, which then would make the use much easier, which also would probably allow the use in less equipped health centers in rural areas. At the same time, there is another compound which is currently under research, under clinical research, mainly in the Democratic Republic of the Congo. It belongs into a novel class of drugs. It's called oxaborols. Boron is an element, and this class of drugs carries boron as an entity, which is very, very rare. That's kind of an exotic compound. At the moment, this research is ongoing, and we hope, if successful, to actually eventually be able to treat sleeping sickness with a single dose medicine, which is an absolute success story. We are coming from treating sleeping sickness 35 days with an organoarsenic drug, 5% fatality rate, going into NECT, nifurtimox-eflornithine combination therapy, still 14 days of treatment with a fatality rate down to 0.1%. Already this is an absolute great step. Into fexinidazole, which would be then an oral drug, making the drugs better available, reduce hospitalization time, and then you have to imagine treating such a massive disease, a potentially fatal disease, with a single dose. So we have come a very, very long way in the past 25 years.